Good morning. Welcome, everybody. I'll just give people a moment or two to connect and join the webinar. Fantastic. I'll make a start as people are joining. My name's Ruth Bradbury. I'm Senior Programme Manager with the Health Innovation Network for South London. Really pleased to be here today to bring to you our latest Innovation Insights webinar. If you haven't joined one of these webinars before, they are free to attend webinars delivered by the Health Innovation Network for England. And they are really here to showcase different examples of where innovation has been brought in to improve patient outcomes and drive system improvements. Today, our webinar, as you can see from our slide in front of you, is focused on women's health innovation and from pilot to spread and adoption. And we've got two fantastic innovations to bring to you today to showcase the work that they've been doing. If I can just double check, I did see there was a message saying somebody couldn't hear. So can I just confirm that the sound is working for the majority? Seems to be okay. Okay, fantastic. I will continue then. Lovely. See lots of hands up. Thank you. So if I could ask for the next slide, please. Thanks, Lauren. So I'm just first of all going to set a little bit of scene, set a bit of context for our webinar today. So across the health innovation networks in England, women's health is becoming a much bigger focus and a priority of our work, either through national programmes or through local initiatives as well. And obviously this sits within the context of the National Women's Health Strategy from 2022, which sets out that women are significantly disproportionately affected by ill health and disability. So there's lots of work here to be done to support women to have better health and to manage their health needs accordingly. We know that the Women's Health Strategy is due to be refreshed any day now, waiting with bated breath for that refreshed strategy to then align with the NHS 10-year plan and the 3 shifts. So making sure that we can transform our services from analog to digital, bring services closer to home into the community, and also thinking about how we improve that shift of care for patients. I just want to say a little bit as well. I mean, I've flagged that the health innovation networks across England are doing lots of work for women's health. But at the Health Innovation Network for South London, we've been doing some work over the last 3 years, working with women's health innovations. So thinking about the topic of femtech. And we've done this through running some accelerator programs in coordination with Innovate UK and their Biomedical Catalyst Fund programme. And that's been a fantastic opportunity to really drive development of innovations and support those innovations to build the evidence to support their implementation. We have run our Accelerating Femtech programme now for 3 cohorts and have worked with over 43 companies or 43 innovations. And alongside that, our universal offer work delivering innovation clinics to companies in the women's health space. So there's so much work happening from both the innovation side and from the health innovation networks too. We've also been involved in various projects supporting women's health innovation. So projects around maternity and neonatal safety, gestational diabetes, and also thinking about evaluation and insights work around maternal and neonatal health. And this is really leading us to form great networks and opportunities to shape policy and strategy through our relationships with the Royal College of Obstetricians and Gynecologists and getting involved in different conferences and events such as HET and Rewired and the Best Practice Conference as well. So there's a real platform here for change within the women's health sector, and really, really pleased today to be able to showcase and drive forward some of those opportunities. So if I could take us to the next slide, please, Lauren. Just a little bit then around what we're going to do today in our webinar. We have got 2 fantastic innovations to showcase with you. First of all, we're going to hear about the adoption story for Squeezy, and we have Chrissy Edley, who is the clinical team lead for pelvic health physiotherapy with Milton Keynes University Hospital. And then Chrissy is going to be joined by Chris Robson, who is the CEO for Living With, to answer more of your questions around their product. We're then going to move on to hear from Satvinder Lal, who is the GP and Clinical Director for Medway Valley Primary Care Network, and how her work working with Adora has shaped the development of that innovation. And then Satvinder is going to be joined by Jean and Ledger and Nuala Foley to answer your questions around the work that they've been doing. With the Q&A sections, I would encourage you to use the chat function. And then as we get to those parts of the session, I will help to facilitate those questions being answered by our speakers. And then we're due to close at about 12 o'clock. So I'm going to move us on swiftly now so we can get into the detail. I'm going to hand over firstly to Chrissy, who's going to talk to us about her work using Squeezy. Thanks, Chrissy.
Hi, everyone. Thank you, Ruth. So yes, I'm the clinical team lead physiotherapist in pelvic health based at Milton Keynes University Hospital, but my work does cross over with BLMK, so Bedford, Luton and Milton Keynes ICB. Next slide, please. So our innovation is using digital triage and launch of a new patient self-management app for stress incontinence, overactive bladder and mild to moderate prolapse. Next slide. So within our area, it's not unique to our ICB. It's certainly a national problem of increasing waiting lists, both within pelvic health physiotherapy, but also across urogynae and gynae services. So we identified this problem, developed our plan. We've got some early results to show for it, and we're going to go through what the future lies with the app. Next slide, please. So the problem is those extensive urogynae waiting lists and pelvic health waiting lists. As Ruth has already alluded to, there's a lot more light on pelvic health and women's health issues. And with our problem locally, it was highlighted that there was also poor knowledge within primary care related to the NICE guidance on pathways of care and best practice. So we often saw that this pathway for patients where GPs would refer patients with stress incontinence, overactive bladder and mild to moderate prolapse directly into urogynecology, where they'd sit on a waiting list for up to 2 years. Our trust has got a very high waiting list in the country compared to some other trusts. Patients would then see their clinician and be told, actually, you need to have pelvic health physio to support your symptoms before we can take it any further. So they then come and sit on our waiting list for 6 months. And then those that needed to would then go back on that long waiting list to go back into urogynecology for any surgical management options. And obviously, that's not great for anybody. It's not great for NHS costs and efficiencies. It's not great for the patients. And we see the increased patient complexity. Next slide. So our plan was a multifaceted approach with support with the women's health stakeholders across the local ICB. We started off with a series of train the trainer events, which we had shared with us from our Dorset ICB, who'd been supported by their local health innovation network. And we reached out to all healthcare providers that would get involved in vaginal examination, for example, as part of their usual care with installation of contraceptive smears, biopsies, that all of those sort of treatments to give them confidence in how to assess and identify pelvic health dysfunction and teach a pelvic floor contraction. We've been really working with the ICB and our stakeholders to redesign pathways from primary into secondary care to avoid that direct secondary care route and get women into physio first. And that's where the patient self-assessment and triage app has come in. And that's what I'm going to talk about today. And then we finally finished off the plan with the community outreach events to talk to those patients within our community who don't have digital access or struggle to access English and NHS services to provide some equity in our care. Next slide, please. So our proposed pathway within Milton Keynes, we routinely had self-referral direct into pelvic health, physio for urinary incontinence, but not for any of the other conditions. So this proposed pathway allows patients to either directly refer into the Squeezy pilot through the advertising campaigns, which I'll talk about shortly, or come via their GP directly into the app, or GP can refer into physio, who can then refer them onto the app if they are appropriate. The app then is the top pathway. It involves an assessment program, clinical review, treatment program, clinical review, possibly into a physio if that's then needed, and then following the usual pathway into urogynecology if more treatment is needed. Next slide. So the pilot that we've just in the process of finishing has been a 6-month onboarding phase. We had 3 designated GP sites really working hard at onboarding patients. We also onboarded patients from insourcing urogynecology clinics, which were laid on to help manage our waiting list. And then we obviously had the self-referral pathway. We produced media in the form of posters, leaflets, and digital posters that were advertised in GP surgeries, as well as on Facebook and Instagram as well. Next slide, please. So the onboarding, I said, took the shape in those various communication methods. We had posters available in the consultant clinics and the GP practices as well. By using a QR code, patients could complete a self-registration form, which initially talks about who the pilot is aimed at, and with basic eligibility criteria. It then talked through red flags for safety netting, so anyone with any red flag symptoms were not accepted onto the pilot and were directed back to the appropriate services. And if patients felt that they met all of those criteria, then they could go to fill in their details, which then allowed them to be set up behind the scenes at Squeezy. Next slide, please. Following that setup, an assessment program was sent to the patient, which contained an assessment questionnaire of 4 or 5 symptom questionnaires with some free text to talk more in depth about their bothersome symptoms, as well as any complex past medical history. They were asked to do a bladder diary, ideally for 3 days. We have had some modification of the pilot, and we've allowed 2-day bladder diaries to be accepted. And then on completion of the bladder diary, the patient ticks the box to say, I've completed the programme, and that leads them to the clinician role. Next slide, please. So at this point, the clinician becomes involved, and from the dashboard behind the scenes, we can have access to their bladder diary, see the answers to their self-assessment questions, and then based on those answers, we can allocate them the most appropriate treatment programme. Next slide, please. So it's back over to the patient. So we've just involved the clinician for that short triage period. We update their patient plan with the right programme, and each programme involves a 12-week treatment plan given to them once a week on the same day. Even if they complete the tasks on day 1 of that week, they need to wait a week for their next parts. They can't rush through it in a week in total. It involves reading, assessments, outcome measures, further bladder diaries, pelvic floor training information on and how to progress into functionality, and support from the actual Squeezy app, which is a pelvic floor training reminder system. and then quizzes to support patient knowledge and understanding, with the ability to go backwards and forwards through the app to reread sections that have already been completed to ensure understanding. Next slide, please. So clinician involvement is fairly minimal at this stage. Initially, the exclusion of patients for red flags, including a complex past medical history, whether they're in their perinatal period or digital access, will automatically exclude some patients. Once the patient has completed their assessment, if they highlight complex pelvic floor and pelvic health or other past medical history, we have the ability to exclude them at that period or contact them for further details, and then we direct them into the correct and most appropriate pathway. Nudges are sent automatically to complete the bladder diary, and for those who are struggling to adhere to the programme, just getting a little bit slow completing homework. Next slide, please. So the results are a bit of a work in progress. We've just finishing the data collection, and as you can see there, we've had 175 patients invited with 144 registered. We're actually working with 77 patients who are actively going through the 3 programmes. 48 patients have been removed from the pilot for different reasons, including non-compliance. When we've contacted patients, they felt that now is not the right time to complete their treatment, or they found it too difficult to do the bladder diary. But as you can see, there's been over 3,000 activities completed by all of the patients within the pilot, and multiple assessment tools have been used for patient recorded assessments in terms of anxiety and symptom scoring. Next slide, please. So this is an example of the stats that we can see from one particular patient, taken as an example. The standard blue at the bottom is the exercise completed. They've been very diligent, completing their exercise 3 times pretty much every day for 10 weeks. The purple is the programs that the tasks and they've completed. So this patient has had really, really good adherence to the program. So we'll look forward to seeing the results of that at week 12. Next slide, please. So in terms of savings and efficiency, if we look at normal care, a patient with one of these symptoms would either be accepted as a new patient as a one-to-one, typically with a band 6 qualified physio, for one new patient appointment followed by 2 or 3 follow-ups, or they may attend a group session and then be followed up with 2 or 3 follow-ups, depending on the complexity and preference. A normal patient would involve about 3 minutes, generally of a band 7 triage time, and that would equate to between 105 and 150 minutes of band 6 time, depending on your service, whether it's 30 or 45 minutes for a follow-up and 45 or 60 minutes for an initial assessment, plus 3 minutes of band 7 triage times. So quite an extensive period of treatment time per patient. When we involve the Squeezy pilot, we're looking at about 15 minutes maximum of a band 7 triage time, then 12 weeks of self-directed care with an optional access to a 30 to 45 minute follow-up appointment with a band 6 for those patients who feel that they need a little bit more face-to-face care. So saving a minimum of 60 minutes per patient. If a patient completed 6 weeks on the pilot and then decided it wasn't for them, or their symptoms were a little bit more complex, their likely follow-up may be a new patient and a follow-up appointment, which would equate to about 75 minutes of treatment time, still saving 30 minutes per patient. Next slide, please. So thinking about developments to come, we're currently doing a full evaluation of the pilot, particularly looking at adherence levels and whether mode of entry into the pilot, whether self-referred or via clinician direction, has a significant effect. We're looking at better patient guidance for bladder diaries, automatic nudges for extended pauses, and potentially automatic removal with extended pause, and maybe making a more modular treatment to remove some of the sort of standardized pathways for those platforms, and potentially introducing some technical clinics and further clinician support to be taken at choice by the patient, and then looking into other pathways in a pilot of the version 2. Next slide, please. Thank you, and happy to answer any questions.
Thank you. Lauren, maybe if we could just take them down the slides for a moment, and then we can go into our Q&A session with Chrissy and Chris. So I'm going to welcome Chris Robson onto the screen for everybody. Chris is the Chief Exec of Living With. Chris, I don't know if you just want to say a little bit about yourself and how you got involved with Chrissy as well.
Yes, so Living With owns Squeezy. So Squeezy's been in the market for over 10 years. We've been working with Chrissy for since 2018, I think 2017, 2018. And there's a lot of new work that we're doing on Squeezy Connect. So to enable it to tackle more of today's issues. And this pilot is one of the first steps in that direction. So very interested to hear from anybody who wants to know more, get involved.
Fantastic. We have got one question in the chat, which I'm going to come to in a moment, but I just wanted to ask the two of you, I mean, at the start of the presentation, Chrissy, you really outlined that problem of waiting times for patients. I know that you're still kind of midway through the pilot, you're looking to finish, but have you got any indication at this stage around kind of how those waiting times might be impacted?
I definitely think there's been a lot of patients who have really welcomed accessing care immediately. The ones that we've clinician onboarded and who have been sort of referred from one of those sources have remained on our waiting list because it's a pilot and we didn't know whether it would be successful or not. But definitely patients have been keen to trial this while they're waiting, because to save them waiting with nothing. So I think it really benefits the sort of waiting well aspect of care, that they can start doing something to help self-manage their condition, and empowers them. We haven't got the data yet to see if we're reducing our referral rate, but I think that will come when we look at rolling it out further and when we look at the actual data we've got.
And I guess that calculating that clinical time that you have, I guess, released is a really important part of this process as well. Is there anything more that you kind of can add to around that?
Yeah, I think, I mean, we know that digital access isn't for everybody, but it really helps to free up clinician time to the increased complexity of patient that we're seeing in pelvic health, so that we've got the right people being treated in the right place. We did have our first patient came back off the app a couple of weeks ago, and she said, actually, I don't need any more care, I'm better. So we know that there is that facility to work, and it's just getting the right care at the right time in the right place, really, to, as I say, to empower.
Yeah, and be flexible for the patient and the needs.
Absolutely.
Yeah. Perfect. Well, listen, there are a couple of questions in the chat, so maybe we can address these. So Ben has asked a question. He was really interested to hear about the effectiveness of your nudges. He says, what prompts did you use? Did you try different calls to action? And what did you learn that you would use again?
So do you want me to pick this up initially, Chrissy? Yeah, I mean, what we're seeing, we're actually in the second pilot we're going to do. We're going to use more of the learnings we've got on which nudges work better than others. And we're also going to do some further testing of different types of nudges. One of the most interesting places to start from a nudge point of view is who's nudging you. is it actually a clinician who's nudging you? Because what we see time and time again is that patients only need a tiny bit of contact from a clinician as a nudge or as an explanation of why they want something for it to make a phenomenal difference. So that there sort of is a difference between a personal message from a clinician saying X versus just the app, as it were, telling you to do something or suggesting something. And we're experimenting with that because one of the things we're looking at is, for example, if you run groups or webinars up front with a clinician for a small amount of time, can you set the expectations that then drive patients for quite a long way on their own? And is that a good use of time? So there's a whole array of learnings to come from the use of clinicians as the nudges for the patients. Secondly, another part of this whole process of getting patients to look after themselves is how long do you give them to do something on their own? And as Chrissy was saying, do we need to make that more modular? And do you just allow them to go at their own pace, or do you control their pace? And there's evidence that some nudges where, a patient wants to move on to the next section, as it were, you can tell them that, yes, we can allow you to move through to the next section, but the evidence suggests it would be better for you if you take more time. Again, is psychologically quite good because it makes the point that they have their own control, but they don't have to take it up if the evidence suggests they'd be better not to. So it's worthy of a lot more conversation. There's so many pieces I could say on nudges and what does and doesn't work, but to come back to.
Maybe I can pause you there because the questions are coming in thick and fast, and we are going to run out of time eventually. But we do have a question that's around age brackets of the users. So Chrissy, maybe that's something you can pick up on. And then also there's a follow-up question to that around were there any trends in the ages and uptake compliance? So maybe briefly you could answer that.
Okay, so we've automatically made it over 18 and for women outside of their perinatal period, so not in pregnancy or for the year postnatal. But absolutely, we've got a whole range of ages, and I think the oldest people we've got on it is about 70, and they're working well through it. We haven't got the numbers of age brackets yet that I'm aware. Chris, I don't know if you know more on that, but I think it's a well spread age.
Yeah, so I guess as you might expect, the majority of Squeezy users are in the 25 to 44 bracket. We have the next biggest chunk is in 44 to 60, and then there's a bigger chunk above that. But we have 90-year-olds using Squeezy, so age is not the driver of whether people do or don't use it. It's can be technology, but for most that isn't such an issue now. It tends to be more people's inclination to do this for themselves.
It's always really great to see that there's breadth and there's real variety in people accessing technology. And I think, yes, dispelling the myths that age is a barrier, I think, is really, really important. I'm going to bring our Q&A to a close. It's rushed by super quick. There are a couple of questions in the chat that are around kind of around sort of industry, companies like Living With working with the NHS and kind of how that happens, how you kind of build that relationship over time. And I wondered, Chrissy and Chris, maybe that's something you might be able to just respond to in the chat. Because I think that's, it's really, they're really important questions about how do you build those relationships, how do you sustain them, and how do you make sure that you're building a product that works for all parties. So maybe if I could ask you to do that, that'd be fantastic. Thank you so much to Chrissy and to Chris for telling us about the pilot with Squeezy. I'm going to move us on now, and we're going to hear from Satvinder Lal, who is GP and Clinical Director with Medway Valley PCN. And Satvinder has been working with Adora. So I will hand over to you, Satvinder, and to talk us through your presentation. Thank you.
Hi, thank you. So I'm Sati. I'm a GP partner in Kent and Medway. I've been here for 20 years, and I have a special interest, I guess, in women's health. I was the only female GP at the practice when I first started, so it sort of landed in my lap. I'm also the clinical lead for the Women's Health Hub in Medway and Swale. And when we first started looking at Adora, we actually were working quite closely with, I was part of Medway South PCN. Since then, we've split away from them. So just for a bit of context, so essentially the app was used across 2 PCNs to start with. I think what we were really looking at was looking at whether we could use apps to support consultations in the menopause and also empower patients with coming to sort of see us with a bit more empowerment, being able to ask the right questions and that sort of thing. Essentially, we had been starting to see a number of sort of increasing menopausal related consultations, and this was prior to a lot of the publicity. So as a PCN, we were really lucky. We had some health and wellbeing coaches that we'd employed, and we were working with Medway Council, who actually co-employed our health and wellbeing coaches, and consequently, we actually set up some menopause coaching sessions, which entailed a GP doing some clinical information around what menopause was, what sort of treatments were available, talking through patient-friendly, as it were, clinical things like, this is why blood tests aren't relevant and that sort of thing. And then lots of the patients from the feedback, they found the menopause coaching sessions really helpful. They felt a bit more knowledgeable when they were going to see their GPs. But GPs were then struggling with the time of consultations because they were having to really ask lots of questions around menopausal symptoms, which should happen, but in a 10-minute appointment, it was quite challenging. So we were looking at ways that we could get information from patients. Patients could have a comparator log, and that's when we were introduced to Adora. Now, I don't have any fancy slides like Squeezy did around what the Adora app looks like, but if we can go to the next slide, please. This is what I'm talking about, co-design practice. Next slide, please. So we had an introduction to Adora through HIN, and it seemed to fit all the things we were looking for, and it seemed to align with our women's health objectives. We had a number of phases of rollout. So essentially, before we sort of applied for research and everything else and thought about clinical and information governance, because those were sort of things we hadn't really considered, and I'll talk a bit about that later on. And initially what we did was, so if I go back, actually, Adora's an app that allows patients to do a menopausal self-assessment, and there's AI-based conversations. So there's a chat bot and next steps and sort of answers questions, and there's lots of evidence-based information for patients to refer to. So what we initially did was got the clinicians within the PCNs to have a look at this to see, is this something that may be relevant, may be useful, or actually is it something we might as well not try? And it was great because what we managed to do was not only get some feedback, but also have some input into what could be better, what maybe wasn't very useful. And we were able to feed that back into Adora, who were very responsive to all the suggestions that we came about with, and I thought that was really helpful. We also offered it to staff so that we could see it from the sort of user interface end. So 10 members of staff agreed to give it a trial. Again, they were aware that the data was relevant to them. It was anonymised apart from having an account with Adora. But we were very clear about counselling them in terms of what it was going to be used for and what it wasn't going to be used for. And we introduced the concept of the idea to our women in the women's coaching sessions, and they all seemed quite interested, and we collated feedback from the clinicians and staff members, and again fed it back into Adora, who were very responsive. Next slide, please. So once we'd sort of gathered the data, I think Jean, who is on the call and will be answering some of the questions, applied for a UK Research and Innovation grant to look at an evaluation really of Adora menopause support in primary care. We focused on feasibility and how to implement it very safely. And this is where the exciting stuff like information governance came in. So what we really needed to do was look at the usability, clinical value and safety, and very quickly realise that it wasn't just about clinical issues, it was about digital governance as well. So I had done some CSO training by this point and very quickly realised that there was a lot of stuff that we needed to do. And Jean helped support this, and we were really lucky with getting the funding from UKRA. So we had to look at DTAC compliance, which is complying with NHS digital requirements, and eventually it was approved as a medical device type 1, and I'm happy to answer questions about this later. Looking at co-designs of versions that work in the primary care pathway, understanding what menopause support was needed, and thinking about self-educations. So things around information governance were around sort of where the data was stored, how it was managed, applying clinical safety positions, and as I said, principles, sorry. And as I said, this is where CSO training came in really helpfully, but also slightly, I guess there's a risk of restricting innovation sometimes when we think quite a lot into the safety principles that are needed, but again, very, very relevant and very valid, especially as we're introducing more tech. Whether we could realistically fit it into primary care workflows, was it adding to more workload, but also did it integrate with patient records and that sort of thing? And then finally, again, picking up on what Chrissy was talking about was digital inclusion and usability across patient groups, and that's quite important. Again, the pushes towards the NHS app, we know that's a national thing, but there are patients that can't use things. So we had recognised quite early on this wasn't going to be suitable for everyone. So we had to work, and Jean did a lot of this work, so I'll give her lots of credit, around getting HRA ethics approval, using some ICB data, looking at focus groups. And initially, because we were just using staff surveys and staff data, ethics approval wasn't needed at that point. And then we moved on to getting ethics and doing an 8 to 12 week feasibility study where 50 licenses were offered to patients to really come back with getting some feedback and things like that. And initially, we sort of targeted menopause groups to start with. And as I said, you know, functionality alone wasn't enough. The governance was critical. So we identified 3 main things from the initial sort of exploratory. Is this something we want to use? Staff engaged really well with it. They really valued the tool. I probably should go to the next slide, actually. I'll just ramble on otherwise. There was some clinical benefit they felt around consultation quality, but as I said, governance and integration remained sort of very significant considerations. Staff themselves that were using it, who were perimenopausal, actually felt that they had a better understanding of their symptoms. And as I said, we then went on to do the UK research stuff. So some of the challenges when we did the exploratory bit was part of the app, it actually referred into a private provider. So that wouldn't have been suitable for our NHS patients, especially those that wouldn't be able to afford it. There was poor integration with GP systems, and I'm not talking about digital integration. It was actually having GPs aware that a patient may come in with their own self-assessments and how we could compare those. Again, concerns around engagement and how we would do that. So we also went to a women's health conference, which was run by Medway Voluntary Association, so the third sector, and the Medway Diversity Forum. So again, it was trying to see how things might work. Digital exclusion was obviously a thing, and whether there were data quality issues. So we had staff champions, patient champions, very slow rollout, and we took a lot of time, and it was research backed, which gave us the confidence what we were trying to do was actually relevant and something we could put in. I think what was really important, I think for me to stress, is it's not really a plug and play solution when we first started looking at it, and it still isn't, in the sense that we can't just plug it into EMIS or patient medical records at this point. It is a lot around patients printing their self-assessments off and us being able to do comparisons. But from a patient empowerment point of view, they were able to track if their symptoms were improving after coaching sessions, after starting HRT, or if they weren't, which was really helpful. Next slide, please. So what we thought about sort of potential sort of benefits were patients hopefully would get better access care, more personalised support ahead of GP consultations, and some improved confidence in discussing sensitive issues. So again, one of the other add-on features that recently was put onto Adora was around genitosexual symptoms. There are a lot of women who present with recurrent UTIs, atrophic vaginitis, things that they might have been embarrassed about, could use the app without having to have that conversation, and then, feel again a bit more empowered to have those consultations. GPs, when we looked at it, found that it did save a bit of time in consultations. Patients were prepared, they could have a fuller discussion around whether HRT was useful, benefits, risk, and that sort of thing. And there was some feeling that it would support safer decision making, although we are still waiting for some of the evaluation to come back. For commissioners, potentially it might reduce demand on the services. It will align with NHS priorities with women's health and also digital self-management, and it could potentially be scalable. I think what I would say is it supported our service transformation in terms of managing menopause, supporting the women's menopause coaching sessions, and empowering patients. And I'd stress that it's not necessarily just about the technology, but actually about the safety sort of considerations. So I think digital tools like this have a real potential in primary care. But I'm going to caveat that with they have to be clinically sound, safe, practical to implement, and, as I say, real considerations to take around the clinical safety elements of digital tech that we implement. So without trying to sort of quash innovation, and as I said on part of HIN, I think had I not have done my CSO training at that point, we could have potentially pursued this in considerable detail. And as I said, Jean supported us a lot with making sure that we were compliant and had all the regulatory approvals in order to support all of that. But there is a risk with all the hazard logs and clinical safety reports and everything else and all the evaluations that people will fear trying something out. So it's just really a bit of caution, but don't let it stop you, is what I would say. So I think that's me. As I said, it's more of a practical, this is what we did. What we'd ideally like for our patient journey is that a patient would receive an SMS link with some information around what the app is, what they could use it for, and giving it a go. Obviously, with all the ethics stuff around it. Patients would then complete a digital questionnaire. GPs could review them remotely prior to a consultation or with a telephone consultation, and then have a focused consultation and decision making process with patients. And as I said, the app itself does signpost patients to some self-help stuff, further question resources, and also questions that you might come back to ask your GP about, which can be really helpful in a consultation. And next slide, please. So I think we talked a lot about this in terms of the PCN feasibility study with Innovate UK. I've talked about challenges or solutions around personalised care. So we're in the early phase of using this, gathering feedback, engaging with staff, and as I said about community engagement. We've had very positive reviews. Adora piloting it in Scotland as part of the CivTech pilot, which has had a high level of interest and support. There's been lots of data collection at ICB anonymised, just really to look at what women's health presentations are like. And we've had some dedicated clinics, as I said, with women feeling quite empowered with digital tools and peer support. Next slide, please. So yeah, acknowledgements. This work was funded by Innovate UK, and it was a feasibility award and delivered in partnership with Adora, Medway South and Medway Valley PCNs, and also supported by NHS Kent and Medway. We've got Jean, I think she's going to be supporting me with answering some questions around being research lead. Jo Finley, who was a health economist at the time, but has moved on since, and Ed Smith, who's the Chief Technology Officer and who was involved with sort of co-designing this. And yeah, thank you to our PCNs, our GPs that got involved, all the feedback that we had, the evaluation partners, the ICB, and especially a big thank you to Jenny Partridge, who introduced us to Adora through the HIN. So I'm open to questions.
Thanks, Sati. Thanks, Lauren. Yeah, take the slides down. Fantastic to hear. It sounds like it was a really real collaborative piece of work that you've been delivering. So really great to hear that. And I'm sure we'll delve into that a little bit more in a moment. Can I invite Jean and Nuala to come on and to introduce themselves, and then we can go into some questions because they're starting to come in the chat. So maybe Jean, do you want to kick us off?
Hi, thanks for having me. So I joined Adora a couple of years ago and secured the Biomedical Catalyst Award. I think it's just, it's really important to flag that what we were looking at is getting the governance sorted in order to understand how you would implement with patients. So we had aimed to implement with patients, but the project ended up being a very collaborative process to work out what groundwork do you need to understand how many women this issues affect who might benefit from a solution like menopause, Adora's digital menopause support, and how could it be implemented with a safe and right frameworks in place. So it was very much a collaboration, and I came in with the grant to support that groundwork about how you can implement via PCNs.
Great, thanks, Jean. And Nuala.
Hi everyone, Nuala Foley, Director of Innovation and Enterprise with Health Innovation KSS. I am covering for my wonderful colleague Jenny, so thank you for the shout out, Sadi. I'll make sure that she knows that. Jenny's on sick leave, so I'll do my best to answer any questions. What I would say though is I did actually first come across Adora myself back, I think in about 2020, when Anne approached us as a HIN with what she thought was a fabulous idea that we could just roll out into the NHS. And I think there was a lot of learning along the way in terms of the realities of that and the challenges. So I just want to say it's absolutely wonderful to be able to sit here today and see how far Adora has come and the support that it has had from the likes of Kent and Medway as well. So just really pleased to be able to be here and see that journey and look forward to seeing the rest.
I think that journey piece is really important, isn't it? Because obviously that initial work with you in Kent, in Sussex, and then obviously Adora came on to our Accelerating Femtech programme as well. So that growth and investment into developing the product to be then suitable and fit for the NHS is great to see. Yeah. Anyway, let's pick up. Jean, you kind of touched on the sort of the regulatory kind of compliance side of things, following on from Sati's talk. But Ben has asked a question. In terms of that sort of regulatory data security compliance, sounds difficult. What would you do differently if you had to kind of go through that again? Maybe a short, brief answer around that.
Yeah, I think it's just really interested in some of these women's tech and innovations where there isn't a straightforward pathway. There isn't a reimbursement model. So what you're starting from is there isn't a comparator even for health economic evaluation in terms of a standard care digital approach. So you're really building this up from the ground. So I wouldn't say there's anything I would do differently, but we've got a really good comparator because we've got a big pilot that's been working in Scotland. And I think one of the important things to say is when you want to do the information governance and so forth, I think it's absolutely right to start with the NHS DTAC, usability, accessibility assessments. Adora has things like cyber essentials, really get that secure for women's health, because trust in evidence-based and secure solutions is your first step. So I wouldn't do any of that differently. I think the one lesson is, how can we pilot at small scale safely as maybe a service improvement project when we've got that information and clinical safety governance? Like, what's the threshold? Because with this project actually going through HRA and a proper clinical study, that can take you a very, very long time, even with proportionate review. We were able to do that in Scotland, but with a lot of R&D and institutional support from an NHS sponsor. And that's not always feasible in primary care. So I think absolutely start with the essentials that you need for NHS digital security, but then work locally to go, how can you do safe, low-scale pilots before scaling up as well? So I think you have to take a flexible approach and keep working with the ICP and local clinicians.
And I think, as you talked about, Sati, it's kind of having the expert in your organisation. For you're the clinical safety officer, and actually that was fundamental to sort of driving the implementation of this pilot in a safe way. So I think that's clearly a lesson learned or a good practice.
Yeah, I think it's really interesting though with the CSO training, because it's not something primary care is used to. And I'm aware that I was really lucky to go on one of the first NHSE funded places for primary care. And there was a bit of a perception that I could do CSO training for all the PCNs in Medway and Swale, or be the CSO, as it were, for Medway and Swale, which I think, again, with the amount of digital things that are happening, each practice PCN is so different in terms of hazard logs and doing the clinical safety reports. They are quite unique, I think, to how different places work. So I think, as I said, had I not have done the CSO training as I was, we would have quite happily had Jean not have been involved, carried on. So we would have thought about, GDPR, we'd considered DPIA, but I don't think we'd really totally considered sort of gravity, I guess, of how important it was to go through those right mechanisms.
Really interesting. Okay. I'm going to pick up on Rebecca's question. She's kind of picked up on the idea around sort of, I guess, interoperability, GPs' access to data. And I think you did touch on this a little bit, Sati. How, because you talked about essentially patients or the users bringing their data to the GP. How kind of viable has that been? Do you see a roadmap where that sort of integration of data is in place?
So we have looked at various options. One option is at the moment we use a clinical triage system called Anima, and we had, using some of the questions and using other questionnaires from the Menopause Society, actually have a template for women that are presenting with perimenopausal symptoms. So we have that interoperability because that saves into the notes and it's all gone through the approvals that we need for the NHS. So again, it's women are otherwise having to come in with 2 bits of data or information. Now, ideally, if those questionnaires could be integrated into the clinical system, so we use EMIS, System 1, Medicus, whatever else is out there at the moment, I think it'd be really useful to have that integration, because you've then got really clear monitoring patterns because of coding, whereas things like the current online consultations, it's not coded data, so it tends to be in a bit of a questionnaire format, but it's quite difficult to then be able to sort of I guess grade the severity of what's going on. So free text is one thing, but actually on a grade of 1 to 10, what are these symptoms affecting you? You know, is it hot flushes? Is it brain fog? So that would be really, really good in terms of next steps. But again, we're still working with Adora around how that might work.
And oh, sorry.
No, I was just going to say, what we didn't have data sharing, but we did get anonymized data from the ICB, because we wanted to understand what the data quality was at a population level as well as the local level. So the ICB were great with that. But we also found there's a lot of missing data in that. So there's missing data on ethnicity, and not many women had a menopause code. That was one of our big findings. So we find a lot more coding for HRT prescriptions than for menopause. So with Sati and the team, we've done a lot of interpretation around what data quality needs to be improved.
And that's a really important point, isn't it? Because I think, you know, when we think about innovations or technology for women's health conditions, you know, it's not necessarily just this plug and play kind of method. It's about that process of service improvement, pathway redesign. It's about uncovering, as you say, gaps in the data. How do we then approach things differently moving forward? So it's fantastic to hear that your collaborative approach has really identified those opportunities. So I'm gonna bring that to a close. There may well be, I don't think there are any more questions in the chat, but please, Sati, Nuala, Jean, do have a little look through. If there's anything you want to respond to, please feel free to do that in the chat. And also, I know that Chris and Chrissy from our previous talk have put their contact details in the chat as well. So Jean, Sati, Nuala, if you're happy to do that as well, and for people to contact you after the event, I would encourage you to do that. It's been a fantastic session this morning. I can't believe it's gone so quickly. We've heard about 2 great innovations, one focusing on pelvic health and thinking about bladder control, and then secondly, thinking about menopause and supporting women with their symptoms in that perimenopausal stage. Obviously, these innovations are in a stage of development in terms of product, in terms of implementation, gathering data, identifying gaps. But what we can see is that there's huge potential here for innovations in these particular areas to go forward. And I think it's great learning that you know, our NHS colleagues are working with industry to be able to enable this to happen. I really do want to shout out the role of colleagues like Nuala and at KSS and across the Health Innovation Network of England, who are working with our innovators, with our system leaders to make this innovation and transformation happen. So thank you very much indeed. I guess on a practical note, I believe that the slides and recording from this session will be published on the Health Innovation Network websites subsequent to today. So please do, and I think it gets emailed out. Lauren will probably correct me. So please do look out for that so you can follow up with any of the information that we've shared today. But as we're coming up to time, I will say thank you very much to all of our speakers, to Chrissy, Chris, Sati, Nuala and Jean for joining us today. Thanks to Lauren for managing the background, and thank you to all of you for joining. I know we've had sort of over 70 people on the call at various points, so it's been fantastic. And look out for future webinars in this series as well. Thank you very much indeed. Have a good rest of your Thursday.
Thanks.